Hi, everyone. Welcome to this episode of Arthritis at Home. I'm Cheryl Cohen. I'm with Arthritis Consumer Experts, and we host Arthritis at Home. It gives me great pleasure, as it always does, to be sitting in the studio with Dr. Stephanie Keeling. Welcome.
Morning. Hello.
I'm first going to tell the audience a little bit about you, Dr. Keeling, before we dive into our topic of conversation today. So, for our audience at home, Dr. Keeling is a former board member and current member of the Guidelines Committee of the Canadian Rheumatology Association and a member and treasurer of the Canadian Network of Improved Outcomes in Systemic Lupus Erythematosus, or affectionately known as CaNIOS. CaNIOS is a Canada-wide group of rheumatologists collaborating to study Canadian SLE patients. She's also the treasurer of the Lupus Clinical Investigation Network, which is a North American network of rheumatologists who are working to improve the lives of patients with lupus. So when you think of Dr. Keeling, think of all things lupus. And is it fair to say, Dr. Keeling, that we can call you a lupologist?
Um, I guess by my exposure to it, I did not do formal training, where some who do are probably more officially that way.
Okay, so there is an official course of training to be called a lupologist.
Well, people can do an extra year of like a fellowship, they would call it.
Okay,
We have one like in my own backyard, Justin Smith at University of Alberta, and many others, and they tend to go to
okay,
places like Toronto. Yeah.
okay, perfect. But primarily you're seeing people living with lupus day in and day out, and that's where your
Yes.
body of research lies. Okay, so now that we know what a rheumatologist is, arthritis care, as well as a lupologist, we're going to dive right in to our conversation, which is about the findings of a survey that Arthritis Consumer Experts conducted in partnership with Lupus Canada at the end of last year. The results are now in. The statisticians have been working on the data. You and our colleagues in the Lupus Working Group have reviewed the data and offered some brilliant insights. So here we go. We're going to talk about the findings of our national survey on lupus in Canada. So first of all, as you know, Dr. Keeling, we're going to report out on the survey through our newsletter called Joint Health Insight. Lupus Canada will also report out on it to their membership. And what struck us all, I think, was how lupus affects nearly every part of a person's life. From a clinician's perspective, what sort of stands out to you the most in the findings in the survey?
Well, I think it really outlines the heterogeneity of the disease, which you've already said by pointing out that, 5 people in a room with lupus can have very different manifestations, and their disease course can, like in some cases, it's just the skin. In other cases, it's largely kidney, but other organs like your heart, your lungs, your brain can be affected. So it's not just a joint disease. And then I think the other point is that when we, look at the results of the survey, there's a lot of variability and unpredictability of the disease. And there's the parts of it that also affect, we call it systemic disease, like it's not just isolated to one place. So it systemic also means it makes you have like those feelings of fatigue and brain fog and things that are much more like total body, if you will. So I think one of the other challenges, which we can see by some of the testimonies of people who elaborated on their journey, is that the diagnosis doesn't always come easy.
Yeah.
And so, sometimes people have a delay in diagnosis, maybe they get misdiagnosed, or unfortunately, it was actually hard to read that. I didn't like to see that, but it was actually informative as a rheumatologist, is some people feel very dismissed in the sense that they're sort of brushed off, or maybe we shouldn't use the term gaslighted, but for their
Yeah.
symptoms that they have. Um, and then another piece of this, I also think, is these are largely people in their prime, in the sense of in their working years, their childbearing years, which is significant. It's not, I know arthritis often gets stereotyped as an old person disease.
Right.
And certainly different types of arthritis affect the whole spectrum from, kids all the way to the very elderly. But lupus in particular tends to be not just an old person. We do get elderly lupus, but we also more likely get people in that sort of the prime of life years, if you will. So I think what the survey is teaching us is things that we do see and experience in clinic, right? So that it is affecting health, but the other parts of your life. Can you go to school? Can you work? Can you have healthy mental health? Sort of redundant there, but and good emotional well-being,
Right.
all while navigating the lupus journey.
Yeah. About 250 people were kind enough and thoughtful enough to participate in the survey. So big thank you for everyone who did. Many of those people who responded, Dr. Keeling, described sort of that difficulty of getting diagnosed. You've already alluded to it in your first answer, including a misdiagnosis or not being believed. So tell us kind of from you know, a science realm through that science lens, why does it remain so difficult to diagnose?
So I think, I mean, if you start by people are having, somebody's having symptoms, they don't have a diagnosis, and the primary care doctor, questions an autoimmune disease like lupus, and they try to refer them to a rheumatologist. I think first and foremost, like many other areas, there can be a delay in access. And it is probably especially more true outside of urban centers. But I mean, I can even say in our own backyard here, I'm in Edmonton right now, that there's a delay, but it is particularly harder for people who live in rural areas of
Right.
Canada, which is many people. Um, we know that I sort of said that before too, lupus does mimic a lot of other things, and a lot of other things can look like lupus. So there's always the need when we see somebody in clinic to exclude other diagnoses, and that can take time. So there's that delay in diagnosis, and sometimes your symptoms may not all come at once. So there's a need, sometimes certain symptoms fluctuate. And so sometimes people come into appointments, even maybe to their family doctor to get referred, or in the rheumatology clinic, and they may be not in a flare, for example, and therefore it's hard to definitively diagnose them at that time. In some cases, the blood work is helpful. In other cases, it's not. So sometimes people feel that there's this particular antibody called the ANA, the anti-nuclear antibody, and it's something we see when we get referrals is if someone's positive, they assume they all have lupus. But in fact, while it is a positive test in all people with lupus, pretty much, there are many conditions with a positive ANA that are not lupus. So that's just one example of how the blood work is a piece of it. The antibodies are a piece of it, your other blood work. But in some cases, a lot of the blood work is not as helpful. And then I think, like any other disease, the earlier you identify or diagnose it and can start treatment, then ideally you're going to reduce long-term damage. I mean, it's no
Yeah.
different than you imagine people having stroke symptoms or a heart attack. And, we say time is your brain, time is your heart muscle. So time is all other organs if they're exposed to long-term inflammation to lead to damage. So I guess obviously what you're hearing is we need to listen,
Yeah.
and it's important. But like everybody else, there's those pressures of trying to see more people and the time crunch. And so I think that's what makes it really challenging.
Yeah. I am thankful that you've drawn that parallel between a stroke, a
Yeah.
heart attack, that timeliness. The health system itself doesn't treat arthritis that way,
No,
frankly.
not at all.
And so
Yeah.
we're kind of trying to push a big concrete block uphill in some ways. I
Yes.
think one of the things that's really important as we counsel people and share experience across our membership in Canada, we like to just remind people to be persistent about explaining to their healthcare provider that what they're experiencing isn't normal, that they've never had it before, and all of a sudden, this symptom has come up. And often that persistence really does help the healthcare professional. Yet as patients, we feel a little reticent to
Yeah.
push like that. But it really does help. And you've sort of put your stamp on that by saying listening is essential in diagnosis. So thank you for that sort of validation, Dr. Keeling. The report from the survey shows that medication use is high. That's not necessarily a surprise in this patient population.
Right.
But people then still reported significant physical and daily activity limitations.
Mhm.
So, how should patients understand that? They're telling us through this survey they're taking a lot of medications, but then they're also saying, I still can't do stuff in my life.
Yeah. Yeah, like I think it speaks to um, the ideal world and what actually translates into lupus care in Canada, right? So, we do need medications as like the foundation for lupus care. The classic that many who might be familiar with lupus know is anti-malarial drugs. So hydroxychloroquine would be like the anchor drug for lupus. And it's recommended by different associations internationally, including in Canada. And so I think, and then on top of that, other medications that are needed for the various types of lupus are important. But we know that additional sort of like adjunctive treatments like physical therapy, occupational therapy, um, promoting physical activity, looking at people's like daily function, whether that's work productivity or just can you open a jar, can you get up out of a chair, um, that piece I think is not always translating into what we deliver in the clinic, right? Or and
Right.
so I think that this report kind of recognizes that okay, great, the medications are acknowledged as an important piece, but we also need to remember that people are quite impaired by different pieces of the. I guess everybody's a little different, right? But in general, I think one of the biggest things we hear about is fatigue and pain, and this impact on their life. And there's also in some cases with lupus, if we can control the disease activity, sometimes people still don't feel better. They may come into a rheumatology clinic and we say, hey, your blood work looks good. When I examine you, you look good. The classic features of your lupus are either quiet or completely gone. Two thumbs up, this is great.
Yes.
But then they say, yeah, but I feel like, well, I won't say it online, but I feel bad and I feel tired. I can't think straight, or I have pain in particular areas or whole body pain. And so even when the inflammation is controlled, there's a good chunk of people who still just don't feel like they used to feel prior to their disease. And so, doing things like physical activity, promoting that, however that might be, and then also looking at their pain and trying to promote like a multidisciplinary approach to that is is not being delivered effectively based on what we hear on the survey, really.
And it's also tempting, as a patient myself living with rheumatoid arthritis, it's tempting if you're not, if you're on medication, which, as you say, is foundational in these
Yeah,
autoimmune diseases, and you're not feeling well, the temptation is just to say, well, the medicine's not working, I'm going to stop.
yeah,
And that can lead to very negative consequences.
yeah,
It's that steady state of medication that's allowing them to do just even a baseline level of activity
yeah,
in their lives.
yeah,
And sometimes patience is a virtue, waiting for it to kick in, so to speak.
yeah, yeah.
So be patient, everyone, and work with your room. Um, Let me ask you this. So we talked as a working group when we first looked at these uh, results about the results, the findings that came in around challenges with sexual and reproductive health,
Mhm.
mental health, things like employment disruption. You've already mentioned that a little bit, and quality of life. Those were sort of big, major themes in the
Yeah.
survey. And a lot of the findings were sad, right? Disappointing.
Mhm.
And
Yeah, yeah,
were alarm bells to me as someone who does advocacy work in
right.
Canada in her organization. So, what does that tell us about lupus care in general in Canada?
I
And
think
it's not
that
all doom and gloom, I know.
Oh, no, yeah, that's true.
Yeah,
It's not like we're making huge strides. Like mortality from lupus has come back to close to what is baseline, which I know sounds morbid that I'm saying that, but like 20, 30 years ago, a good percentage of people had a 5-year life expectancy that was reduced considerably, right? So
yeah,
so
yeah,
we've made great strides and there's new therapeutics coming.
right.
But but there is still this impact that on, like we said, like 80% of people have anxiety, they have depression, they can't sleep well. And the factors of their disease are important players in promoting these particular like problems. We know like 1 in 5 can't work. Another 1 in 5, have to work in a adapted, like modified work hours. And so I think there's both the obvious, which is that their income is at threat, right?
Yes.
And therefore their family and or schooling or their being able to go to have their job, their independence, those who rely on them if they have dependents or kids. And there's that element always of uncertainty because both the disease itself, can be a little more unpredictable than some other chronic diseases. And so living like that, and then also the impact on your mental well-being and your financial well-being and so forth is really important. And so I think those don't necessarily get a frontline seat in the rheumatology clinic. I think it's not a lack of interest. It's because maybe there are gaps to acknowledge that, right? Like I think there's a lot of issues across the provinces with respect to how disability works, how you get it. I'm not going to get into that because that's a whole, probably another topic
It's
to
another
do again.
episode.
I
Yeah.
know you've done that, but I think having a better liaison, with in Canadian rheumatology clinics, so we have better access for these adjunctive things, whether it's, I've already said, things like the allied health colleagues and physio and occupational therapy, counseling, social worker, or people involved in trying to facilitate how one adapts with one's job, flexibility in the workplace, which I think now different. I think mandating work, coming back to work in the office has become a bigger thing just recently
Yes.
again. And I
Yes.
have, patients where that's a problem. And so all of that is important. And then I think the one that's the taboo word, sex, right? Like there isn't, I think, a little bit less fear to talk about the impact on your like personal relationships and sexual function and the long term there, because both physically and then also just you're exhausted, and then if you're depressed and have no energy and you're fatigued, it's very hard to maintain an intimate relationship for many people with chronic disease like lupus.
Yeah.
And that is not probably really well addressed. And to be honest, like with the lupus care and others, I'm not even sure how that works, but I think it opens the conversation from this area.
Yeah, yeah, exactly. And we both know that you have colleagues who have openly stated, I don't feel comfortable talking about
Yeah.
those things in clinic. And yet in our survey, our respondents said, this is a big problem and it's
Yeah.
something I need help with. So I will give our joint health education programs a big shout out here. We just launched one with Dr. Susan Bartlett on arthritis and mental health, and lupus is
Nice.
part of the big arthritis family. So it's a disease agnostic, right? That course. So I
Yeah.
encourage people to go check that out because once you gain command of some of the language that helps describe your mental health or your sexual health, you
Mhm.
may be more inclined to bring it up in clinic.
Yeah.
And finding ways to say, geez, doc, this may make you feel a little uncomfortable, but here we go.
Yeah.
I'm having trouble with it. And that might be a nice way to broker the conversation,
Yeah.
right?
I agree.
And
Yeah.
you learn together. Health professionals are not perfect, nor is there a perfect patient, right? There's
Yeah.
perfection doesn't exist. We just try to work together in the struggle of lupus to find the right way for
Yeah.
each and every patient. I know how busy you are, so we're going to wrap up with this last question. The report, and we typically end here, Dr. Keeling, when we're talking about our survey results because they're very consistent across topic. But the report on lupus really highlights disparities in access challenges, especially for racialized communities. So we're talking about Indigenous peoples, Black, other racialized communities, or underserved communities. Why is it so important to address this, especially in lupus?
Well, I think especially in lupus because it is the marginalized populations that have the greatest prevalence. So,
Right.
and if some, I know this might be controversial, probably not for you and me, but some
No.
may argue that females are a marginalized group of people. But more importantly, and as equally, if not more important, it affects like the prevalence is really the greatest in what the BIPOC population, so Black, Indigenous, people of color. And so we know that, like, the impact that and social determinants of health, like geography, costing, accessing things means that inequities are much greater. I think we
Right.
see in our clinics in many provinces, we have a very like large percentage of people that are indigenous, and they are disproportionately affected by autoimmune diseases like lupus, and yet the care is fragmented for multiple reasons. um, and then I think interestingly, when we're trying to do research, we hear about this a lot with our colleagues in the States with like Black Americans. They're trying to have methods to try to improve research in these ethnic minorities because they are the ones that are more affected actually and have the worst outcomes. So I think those are important. And I think interestingly in this study, we didn't have the largest percentage, like they
No.
were largely not BIPOC population. And I think that's acknowledged that that's like a weakness, but you're only as good as who you can survey.
Yeah.
So I think that if we're hearing from the population surveyed that all of these access issues, all these concerns we've already just talked about, imagine probably how much worse it actually
Oh,
is if you actually had, the ability to actually ask people in the BIPOC group.
yeah.
There's a lot of sensitivities, and I think a lot of challenges in actually getting those things self-reported in some populations for many reasons, like
Yeah.
distrust and stuff like that.
Yeah. Super important conversation. And as you point out, one in and of itself, actually,
Yeah.
to talk about disparities in healthcare. And we will persist in that conversation because it's very, very important to us all. I want to take a moment to thank you, Dr. Keeling. You're always available to us to share your great expertise and insights. We thank you so much for all of the work that you did to help us field this survey and interpret the findings and report out on them through Arthritis at Home and Joint Health Insights. So we very much appreciate you. You're very near and dear to our organizational hearts. And of course, we want to again give a shout out to our survey participants. Without you clicking buttons and sitting down, and I'll add again, the open-ended responses were so rich.
Yeah.
Thank you so much for sharing those extra insights with our team. We look forward to reporting out on some of those as well in this Joint Health Insight. So thank you all very much to those who participated, and we hope those of you who are out there who haven't participated in one of our surveys will in the coming days. So again, Dr. Keeling, thank you very much. We appreciate your time, and we wish you a great rest of week and weekend coming up.
Thanks. And thanks for the opportunity. And thanks for everybody out there listening.
Yeah. Thank you. Bye, everyone. See you next episode.